program, even if it is an absolute failure, is there any change in the awareness of people? Are things occurring? Are people getting any kind of care, etc., etc.? Primary data was collected between 15th October 2008 and 15th November 2008, 1 month. The detailed report gives all details about the sampling, how these people were chosen, etc., etc. 3 groups of people were interviewed. Perceptions of medical professionals, that is the health staff, etc., beneficiaries and patients. And somebody said, when you talk about community mental health program, you should not forget the community. Of course, they interviewed community members as well. How many? 60 respondents from the beneficiaries, 30 respondents from the community, and 10 respondents from the health system. That's a health worker, the trained PHC doctor, etc. So a total of 100 respondents from each district, totally 20 districts into 100, 2,000 people were interviewed. I'm not going to present the whole detail because what is given in 265 pages, they give snapshot pictures of 20 districts and there is a comparative analysis. There's a huge amount of data. Anybody wants to study what is happening to the district mental health program in detail, this is a good document. What did they study? The sanctioning process, the utilization of funds, the kind of procedural problems with government. Again, we heard from the IMH director and the secretary. They had 16 posts, 70 people came. They could select only 4 people. Why? There are rules and regulations about reservation, this class, that class, OBCs, etc. When you use government money, which is a taxpayer's money, which is audited by the Auditor General, etc., there are rules and regulations which have to be followed. Procedures, which ultimately, sometimes work negatively in implementing the program. They looked at recruitment and retention of personnel. Big problem is that we don't have enough people. Another problem is that they go by the old, what was in 96 designed by Nima and some of us, minimum pays, etc., minimum drug. No changes occurred to that. So today you won't get a psychiatrist or a clinical psychologist for that. Even in the government there has been the 5th pay commission, 6th pay commission. So even if you get somebody, you are not able to retain them. They go away to other jobs, etc. So they looked at recruitment and retention of personnel. They looked at the quality and the effects of training. They looked at the nature of the IEC activities, availability of drugs, satisfaction with quality of services, that is from the beneficiary community. They also looked at community awareness. Did they know anything about mental illness? Do they know where to go? Is it to the temple or is it to the PHC, etc.? I will not give all the details, but I will only pick up 1 or 2 comments. Numerous recommendations and suggestions, and some of the issues which are not only from that, but based on my field visits, etc., and my own understanding, I'll tell you as I go along. But to me, one of the most important recommendations was, it was observed that the implementation of DMHP has resulted in availability of basic mental health services at district and sub-district level. As such, it is recommended to expand this program to other districts of the country. Lots of things may not have occurred, but they have made a recommendation, and I understand this is what the government is accepted. Nimesh is here, he will know better. Yes. A wide variety of administrative and managerial bottlenecks. In fact, one of the ways in good districts where program has gone on is that they have latched on to the NRHM, the National Rural Health Mission, which has a different kind of fund disbursing structure. The district level commissioner or the collector is, empowered to do a lot of things. So wide variety of administrative and managerial bottlenecks. It's not because of problems in the core, the technique of the program, that is training, etc., etc., but in the actual administrative management. Shortage of trained and motivated mental health personnel. Shortage of trained personnel is a big problem. But even when you get somebody, is he motivated to do this? That's a big problem. Difficulties in retaining recruited staff, low utilization of funds, particularly for training and IEC. In fact, there was low utilization. That was not for the drugs or the staff, but it was mainly for training of PHC doctors and the IEC activities. A lot more money was available than what they could. And the point this document makes is that, unless you have managerial abilities, sometimes you may not be able to spend the money that is available. When you run a small NGO or when you run a program with limited facility, you are able to much better and much more efficiently utilize money. But under governmental directions, which could be audited, you have to submit a utilization certificate. Things may not be very easy. Sometimes, even if they are not very difficult, many people are not very bored. In fact, many of the doctors whom I met, they say, oh, I don't want to get a memo, I don't want to, have my salary stopped, I don't want to lose my pension, so I only go by rule book. And if you go by rule book, very often you cannot progress, but you cannot proceed. Most beneficial. The other problem was that they were definitely able to decentralize care to the district level, but to the periphery, to the PHC and CHC, it was not very efficient. This is the national 20 districts average. Most beneficiary, 61% access the district hospital as their first point of contact, whereas a similar percentage for CHCs and PHCs were 12 and 11, which means that a lot more work needs to be done. Again, the problem of long distances has been highlighted by Tiruchelvi. If care is available in Nilgiris, there will not be homelessness, there will not be so many other problems. Okay, I will now move to the impact of the North Kerala problem. To my mind, this is probably the best functioning district mental health programs in the country, other than the Tamil Nadu one. I mentioned about Madurai and the report, the ICMR report, what it talks about the Tamil Nadu districts. And you have heard from the health secretary, so I don't have to add on to that. But where is the hardcore evidence? Tirunavakarsu was asking about the evidence. And this is a report which I received last week from Dr. Krishna Kumar, who is the director of the institute. One of the objectives of the district mental health program is that once it runs, it's a community-based program, people should be able to access care closer to their homes in the PHCs, CHCs, etc. And as a result, if the program is going on well, it should be reflected in the total admissions of the local mental hospital. It should be reflected in the total follow-ups, because people are now not coming to the mental hospital, but going to the district health center or the community health center. And they will also be referred, because these doctors are trained not to be full-fledged psychiatrists, but they can manage basic problems, and when they have problems, they would refer them to the medical college or to the mental hospital. Now, the total annual admission of the government mental hospital in Kozhikode, which is probably was very infamous. It is located in a place called Kudiravatam in Calicut. People who are familiar with Kerala will know that it's one of the most ill-famous mental hospitals in the whole country. You may have heard about IMH Chennai in local papers. That's nothing compared to what Kerala papers have written about Kudiravatam. Changes have been occurring, like in many other places. Their admissions were 2,626 in 2005. In 2009, it was only 1836. Their total annual OP follow-ups were 31,802, which came down to 24,000. What is happening? Is it that the mental illness is not there? What probably is occurring? And this is, of course, I'm not presenting the whole data. It is supported by the increasing number of people seen in the CHCs and the PHCs. The total annual OP registration, not admissions, but outpatient registration in the Kozhikode Mental Hospital increased. So it means that there is some kind of an impact. What are the other kinds of issues? Now, these are general issues. I mean, when you say programs are not working very well, you must realize the following. Integration of mental health adds another set of chores to the already overwhelmed primary care clinicians and other personnel. They have everything. They have to do diabetes, cardiovascular problems, cancer detection. The ultimate primary deliverer of all kinds of services in the health system is a primary health center. So you are adding another set of chores. Time available to assess and counsel patients is very limited in primary health centers. Another point which has been, very eloquently made by several people, doing more takes time, and dispensing pills is not simply enough. Vandana made in her presentation that what is this care? At the first level, of course, is giving medication. I don't think I need to add anything more. She has already very eloquently highlighted that how it changed her life, how she is able to come and so confidently talk to this an audience. The first step in any kind of program towards rehabilitation and ultimate recovery is being able to be asymptomatic, and it may require medication. Of course, care includes many other things. So, dispensing pills is simply not enough. Patients routinely seen in primary care, we always talk about the most severely disturbed people who might be having a psychotic problem or, bipolar disorder, but mental health problems are not just that. This morning again the health secretary highlighted the number of problems which lead sometimes people to suicide, suicidal ideation, etc. So patients routinely seen in primary care settings are patients with comorbid symptoms, subthreshold disorders, multiple somatic complaints. Many of them are chronic. They have pains and aches, they have had multiple x-rays but there's no problem, but there might be other kinds of emotional problems. If a psychiatrist sees them, they have subthreshold disorders. There is not enough of any of the symptoms to make a diagnosis and start treatment. These are the kinds of problems which routinely primary care doctors see. Depression is often presented as a chronic pain, chronic fatigue, etc. In other words, what I'm saying is PhD doctors, their training should continue. They should be taught to acquire new skills through practical guidance, in addition to gaining new knowledge through didactic teaching. So we need to revise the training programs. The question is being asked how we can make the district mental health program, and these are all responses to that. Doctors need help in managing medically unexplained somatic symptoms. Now, future recommendation. I'm coming to the last part. I told you, see, this is just an overview. I'm only giving you a snapshot of the current status and impact, talking about some place which I visited and the ICMR report which is available in detail for anybody to access, 270 pages. So 2 questions I am asking. If this method is not the right method, what is the right method? Or is it that we didn't have the ideal situation, so we are failing? So the question I'm asking is, was integration of mental health with primary care the right approach? And the answer to that is yes, and I'll tell you, so all over the world people are talking about the same thing. What is it? What happened after Bellary? Similar programs were initiated in Nepal, Bangladesh, Pakistan, Iran, Palestine, Afghanistan, Sri Lanka, Bhutan. I know firsthand about many of these programs. Some of them were trained in NIMHANS. I have visited some of these programs. What is currently occurring, I don't know, but they initiated programs. Alex Cohen, who is somebody who is a very critical observer of things and who has critically looked at various things, including better prognosis of severe mental disorders in the country. He was commissioned by the World Health Organization to review integration of mental health into primary care. University of London, this is Sumit, who did a PhD under Shishir Jadhav. He has now completed the PhD, published numerous papers on various aspects, good aspects, bad aspects. But he only looked at the Kanpur district because he was familiar with the language. He had links in UP, etc., etc. So Sumit Jain, number of papers. The World Health Report, they all talk about the same thing. Institute of Medicine, it's not just the WHO, this is from Washington, this is from USA. The Institute of Medicine's 2001 report on neurological, psychiatric and developmental disorders, meeting challenges in the developing world.